Good morning. I'm going to go ahead and get started. I'm Susie Seaman. I'm one of the first speakers, and I want to go through some of the introductory slides, and then we'll get right into the program. First, in terms of the faculty, I'm very honored to speak with both Dr. Larry Lavery, who's a professor in the Department of Plastic Surgery at the University of Texas Southwestern Medical Center, as well as Dr. Jeffrey Lehrman, who is with Foot and Ankle Specialists of Delaware County, as well as the Center for Wound Healing and Hyperbaric Medicine in Springfield, Pennsylvania. As I said, I'm Susie Seaman. I'm a nurse practitioner, as well as a certified wound ostomy continence nurse, and I practice at Sharp-Rees-Steele Medical Group Wound Clinic in San Diego, California. We all have disclosures. These are in your handouts, and I invite you to read those. And there is a disclaimer in there as well, which I invite you to read. Learning objectives, what we're going to do today is we're going to be talking about the physiology and pathophysiology of wound healing. And although we're focusing on the diabetic today, much of what we say also applies to other types of wounds when we talk about chronic versus acute wound healing. We'll examine the role of growth factor therapy as an evidence-based biologic therapy for treating diabetic neuropathic ulcers, and I'll be covering those first two objectives. And then Dr. Lehrman will get up and talk about the translation of the science of growth factor therapy into clinical relevance as an adjunct to proper wound care. And then Dr. Lavery will summarize late-breaking safety data on the adjunctive therapy based on PDGF in diabetic foot ulcer healing. So let's get going. So first of all, I'm going to talk a little bit about acute versus chronic wound healing, and then we'll talk about some of the data for platelet-derived growth factor use in diabetic foot ulcers. First of all, and for some of you, this is going to be a review. For others of you, this may be new, but I think it's important for us to understand the difference between how acute wounds heal and chronic wounds heal. First of all, most wounds start as an acute wound, okay? There's bleeding from something, be it trauma, be it pressure, be it surgical trauma. There's bleeding that occurs. And normally, in a patient that doesn't have any underlying pathophysiology, arterial disease, diabetes, venous disease, that wound goes through the normal phases of wound healing: hemostasis, inflammation, proliferation, and remodeling. And these stages of wound healing are very predictable, so that after, depending on the size of the wound, say 3 to 4 weeks in a small wound, maybe a few months in a larger wound, this results in a healed wound. And the bottom line is that wounds should heal within the expected time frame for that particular size of wound. Versus that acute wound, which then has impaired healing because of maybe repetitive trauma, maybe tissue ischemia, bacteria counts increase in the wound, and you get a chronic prolonged inflammation. I'm going to go into more detail about that. And this results in that chronic wound. So acute wounds, let's look at this a little bit closer. So again, you get that one-time injury. There's bleeding, platelet activation, and degranulation. And when they degranulate, they release growth factors into the wound environment, such as platelet-derived growth factor, that calls other cells into the wound environment. One of the first cells on the scene is the polymorphonuclear neutrophil, or PMN. And the neutrophil is a soldier against bacterial contamination. Its job is to come in, kill bacteria, and then it dies off. But also, very importantly, the neutrophil secretes pro-inflammatory cytokines, such as tumor necrosis factor alpha, interleukin-1 beta, and other interleukins that cause a little bit of inflammation. You need some inflammation in wound healing to get the ball rolling on that wound healing, okay? We just don't want too much inflammation. And so early in injury, in wounding, that PMN comes on the site. Within about a day or two, macrophages also start to come on site and start secreting other pro-inflammatory cytokines as well as growth factors. But basically, in normal wound healing, within a couple days, the PMNs recede, macrophages, fibroblasts come into the wound site, inflammatory phase ends, proliferative phase begins, and we go on to granulate, angiogenesis, and a healed wound. Now, we can actually look at acute wound fluid, and we can see the differences from chronic wound fluid. For instance, if you take acute wound fluid, like let's say you create blisters on healthy volunteers and you sample that fluid, or for instance, there are studies where they've sampled drain fluid from post-mastectomy wounds, And they look at it, and they find that it has high mitogenic activity. In other words, you can take a petri dish of fibroblasts, you can add acute wound fluid to that petri dish, and those fibroblasts start dividing. This acute wound fluid stimulates mitosis. There's high levels of growth factors in this fluid and appropriate levels of those pro-inflammatory cytokines. And then, very importantly, a balance between matrix metalloproteinases, or MMPs, and their tissue inhibitors of metalloproteinases. So there's a balance between adequate or appropriate proteinase activity. You need some proteolytic enzymes for wound healing to occur, but not too much. Now look at the chronic wound. Here we have a chronic wound like the diabetic foot ulcer, where there's repetitive trauma from the patient walking on the wound. Maybe there's local ischemia, maybe the patient has peripheral arterial disease, but bottom line is there's high bacterial counts. So if you have high bacterial counts in a wound, what comes on the site? Neutrophils. So you get a prolonged neutrophil influx and prolonged secretion of those pro-inflammatory cytokines. Also in this environment, macrophages have different phenotypes, and there's a pro-inflammatory macrophage phenotype and a reparative phenotype. And in the chronic wound, we found that these macrophages don't switch over to that reparative phenotype. They stay pro-inflammatory. But the bottom line is those pro-inflammatory cytokines stimulate cells to release MMPs. They also inhibit the release of the matrix metalloproteinases inhibitors, the TIMPs. So you get high MMP levels, low TIMP levels, and you end up with this proteolytic environment. Well, what happens? What are growth factors but proteins? What are target cell receptors but proteins? What is extracellular matrix? Protein. So you get degradation of those proteins in the wound. You see decreased cell proliferation, decreased migration, and then you'll see cellular senescence, and voila, we have impaired wound healing. So how do we know that some of this occurs? Well, again, we can look at chronic wound healing. These studies have been done in venous ulcers, diabetic foot ulcers. You cover a wound with a transparent film, and you sample the fluid. And if you take that petri dish of fibroblasts and you add chronic wound fluid to it, not only does that not stimulate mitosis, but the fibroblasts lyse. You see decreased levels of growth factors, increased levels of those pro-inflammatory cytokines, and then again, increased MMPs, decreased TIMPs. So again, this hostile wound environment, this chronic wound fluid. So if we specifically look at factors impairing wound healing in the diabetic, this altered microenvironment that I was just talking about, again, inflammation from that bacterial burden, tissue necrosis causes inflammation, and then tissue ischemia from PAD or impaired microvascular function. So diabetics don't tend to dilate like they need to dilate in response to having a wound. Repetitive trauma, pressure, Dr. Lehrman's going to talk about that. Edema, diabetics have leaky vessels, and edema interferes with wound healing. And then systemic conditions such as smoking, out of control A1Cs. So this slide right here, I always tell people, you know, if you in chronic wound care, when I have like students with me, I'll say just Xerox this one slide and laminate it and carry it in your pocket, because this is the approach to the patient with a chronic wound. We want to, of course, treat the underlying problem, which again Dr. Lehrman's going to briefly describe. We want to prepare the wound bed, which again he will talk about. And this includes debridement, infection control, moisture management, and then use of adjunctive modalities such as growth factors, which I'm going to talk about next. So what are growth factors? Well, growth factors are complex proteins. They're chemical messengers. They allow cells to talk to each other. And basically, they're released from cells. They bind to receptors on other cells or on the same cell. They can actually self-regulate. And they stimulate a whole host of things in wound healing. They stimulate cell migration or chemotaxis, cell proliferation or mitosis, angiogenesis or the formation of new blood vessels, production and degradation of extracellular matrix, and then growth factor production by other cells. So how exactly do growth factors work? Well, I like to think of a growth factor and a receptor as kind of a key and a lock. The growth factor binds to the receptor, and then this induces what's called a signal transduction pathway. What the heck is that? That just is a way to get the message grow, migrate from the outside of the cell to the inside of the cell. And so the message gets into the cell, and the cell responds by either some type of change in cellular activity, such as dividing, protein synthesis, migration, etc. So there are many growth factor families involved in wound healing, and under those families are multiple other growth factors. And today we're focusing specifically on platelet-derived growth factor. So what is PDGF? Well, it's involved in every phase of wound healing. First of all, it's released during the first hemostasis when there's bleeding, platelets degranulate, and PDGF is released. It's critical in terms of chemotaxis, or calling in those cells, the PMNs, the macrophages, fibroblasts, etc. It stimulates fibroblasts to divide. Also, it's chemotactic for vascular smooth muscle cells, pericytes. It stimulates fibroblasts to produce extracellular matrix. It recruits bone marrow-derived stem cells to the area. And it's also very important in the conversion of fibroblasts to myofibroblasts, where that's important in terms of wound contraction. Becaplermin gel is recombinant platelet-derived growth factor, and it's complexed in a carboxymethylcellulose gel. It's like a hydrogel. But it has the CMC gel is a hydrogel with the becaplermin in it. It has biologic activity similar to endogenous PDGF, and it's FDA approved for the treatment of full-thickness, lower extremity, diabetic, neuropathic ulcers with adequate blood supply. So I want to go through the phase 3 trial of becaplermin in the treatment of diabetic foot ulcers. Now, you guys, this is really, really important. I remember when the study was published back in 1998 by Wieman in Diabetes Care. This was landmark, and it still today, over 10 years later, remains one of the largest studies, prospective, randomized, controlled trial in chronic wound care. You know, unlike treatment of cancer, treatment of cardiovascular disease, where you see these huge studies, and you would never have an oncologist treat cancer without data showing that the treatment had efficacy. Yet in wound care, and we still do this today in 2016, we make important decisions about wound care based on a case study. Now, I'm not anti-case study. I've done case studies myself. They spark interest. But again, we need to use data to drive what we do and the decisions we make in the care of our patients. So this was a very important study. It studied the efficacy of becaplermin gel in the care of patients with type 1 or type 2 diabetes with at least one full-thickness neuropathic ulcer of the lower extremity. Prospective, multi-center, double-blind, placebo-controlled, and they looked at healing rates, including complete wound closure over a maximum duration of 20 weeks. 382 patients, again, a huge study. Ulcer size between 1 and 40 square centimeters, and patients had to have adequate local tissue oxygenation as evidenced by TCPO2s greater than 30. All patients were sharp debrided, and then they were randomized to receive either becaplermin gel, again the recombinant platelet-derived growth factor, plus good ulcer care, which included debridement, offloading, or the placebo gel, the carrier gel, and good ulcer care. When they looked at wound closure at 20 weeks, 50% of the becaplermin treated group, again the patients that got platelet-derived growth factor, were healed compared to 35% in the placebo group, and this was statistically significant, highly statistically significant, at a p-value of 0.007. When they looked at wound closure rates, patients treated with becaplermin and good ulcer care healed on average in 12 weeks versus 18 weeks in the placebo group. So you got 6 weeks of faster healing. This also was statistically significant. And I want to challenge all of you to think about, in the care of the diabetic foot ulcer, when we want to get them healed as fast as possible, that 6 weeks can make a big difference. So in summary, chronic wounds, including diabetic foot ulcers, do not follow that expected sequence of repair. They tend to be chronically inflamed. We have to recognize and address issues leading to impaired healing, and growth factors are crucial in the wound healing process, and becaplermin gel, or recombinant platelet-derived growth factor, has been shown to speed healing in patients with diabetic foot ulcers. Thank you. And so I'm going to ask Dr. Lehrman to come up.
Good morning. Susie's just done a wonderful job of showing us how powerful this becaplermin is, and I hope you are asking yourselves, what kind of wounds can I use this on? When can I use this in my wound healing schedule? So we're going to answer those questions, and we're also going to discuss why it is so important to use an advanced treatment option like becaplermin, and not just use it, but use it early in your wound healing schedule and not hold off on using it and not saving it as a Hail Mary option. Every 30 seconds, somebody somewhere in the world loses a leg as a result of a complication related to diabetes. Every 30 seconds. So it's about 8:20 right now. So from the time Susie started talking, 40 people have gotten a leg cut off. And we have 40 more minutes until we're done, which means by the time you walk out of this room, another 80 people will lose a leg as a result of a complication related to diabetes. 5-year mortality rate of a diabetic foot ulcer. The percentage of patients that will be dead within 5 years of developing a diabetic foot ulcer. That number is 45%. Breast cancer is 11%. Colon cancer is 35%, but the presence of a diabetic foot ulcer carries with it a 5-year mortality rate of 45%. That is a startling number, and I hope that really grabs your attention. To not be overly dramatic here, you guys know these people are sick, right? People that have diabetic foot ulcers, and there may be a more serious underlying condition that is contributing to their death here, but make no mistake, there is significant morbidity and mortality associated with the ulcer itself, and oftentimes our repeated attempts and failures to treat the ulcer. We torture these people with debridement every week, every 2 weeks, coming back to clinic over and over, infection, hospitalization, amputation, whittling away. It takes its toll, and it absolutely contributes to this very high 5-year mortality rate and argues that we need to do better. That speaks to the seriousness of the condition that we are dealing with. What about the urgency that is required in treating a diabetic foot ulcer? Is a diabetic foot ulcer an emergency? And the answer is yes. If you're not familiar with the Sheehan data, I hope you hear it 25 times before you leave here this weekend. It's what's presented here. The Sheehan data tells us that if an ulcer is not 53% smaller after 4 weeks of conventional therapy, there is only a 9% chance that it will heal in the next 12 weeks. And if it doesn't heal in 12 weeks, we know what often happens after that. If it's not, we can call that half, 53%. If it's not half the size, in 4 weeks, you now have only a 9% chance of success in the next 12. That is a goal that we should be setting for ourselves. Measuring these, keeping track, and at the 4-week mark, asking yourself, is it halfway smaller? Because if it's not, we're in trouble. This argues for the importance of using an advanced treatment like the Becaplermin that we're talking about early and not waiting. Not starting with something else and saying, well, I'll just use this old stuff for the first 4 weeks, and if it's not better, then I'll use the good stuff. And not playing LCD waiting games of jumping through hoops and waiting 4 weeks before we institute an advanced treatment. With Becaplermin, we have the opportunity to introduce an advanced treatment with the robust evidence that Susie showed us right away, without delay. We have literature that dictates what is good ulcer care and what can guide our decisions. And it's important that we are practicing evidence-based medicine and choosing products that have evidence and literature to support their use, like the Becaplermin that Susie showed us. And there's literature to back this up, to prove that we have the ability to have an impact on these terrible numbers and statistics that we just looked at. Amputation rate, failure to heal, hospitalization, and even death. Study that's referenced here that was led by Dr. Weck shows us that if we have a structured diabetic foot program in place, if we are making evidence-based decisions and using products that have literature to support their use, that we can actually yield a decrease in amputation rates and a decrease in inpatient mortality. So those of us in this room have the ability to have an impact on these statistics, on our communities, on our patients, and on our own outcomes that we achieve in our practices. Good ulcer care is defined by literature and research. We, of course, start by identifying any underlying vascular disease that may be present and getting that addressed. And then we want debridement, sharp debridement combined with enzymatic debridement, studies that support the importance of that. By debridement, of course, we refer to identifying any peri-wound callus, like this hyperkeratosis that we see here, and debriding that away. And then if we see that yellow, fibrotic, non-viable tissue at the base with adequate vasculature to support what we're doing, nice aggressive debridement there to try to get a nice, clean, red granular bed. Infection control, whether that be local or systemic, whatever the wound mandates. Moisture balance, we know we don't want these too moist, we don't want these too dry. And of course, offloading. If we don't get the pressure off a pressure area, we have very little chance of success with anything that we do. And when we've achieved excellent wound bed preparation, and the wound bed is mostly clean, red, and granular, that's when we can introduce the Becaplermin. Becaplermin is appropriate when you have healthy granulation tissue established. When wound bed preparation is for the most part complete and it looks like this, that's when you can hit it with the Becaplermin and introduce that very powerful platelet-derived growth factor. If you are concerned about the cost of the products that you are prescribing to your patients, this study is of interest to you. Led by Dr. Kersner and his associates, who's one of our co-chairs, study showed us that when you use an advanced treatment option early, which may be a more expensive treatment option, when you use an advanced treatment option early, it can actually decrease the overall cost of care for that wound. So by using the better stuff early and not waiting, we can actually decrease the cost of care. And if you read the study, it shows if you use the more advanced treatment option early, you're normally going to shorten the period of time that the wound requires treatment. So there's tremendous savings there. And think about the savings of keeping one person out of the hospital, with an average diabetic foot admission being $80,000. One case study to share with you to demonstrate the power of the Becaplermin that we're talking about. Just to orient you, this is somebody's left foot. So we're looking at left lateral midfoot. The heel is closest to me. The toes are to your left, with the leg going up the screen, just so you're oriented. So we're looking like lateral cuboid area. This is a big, nasty, scary ulcer on a 60-year-old diabetic with an A1C of 12. I'm sure that's none of our world records, but that's bad, right? So we picked a bad one to impress you with. This is a big, giant, scary ulcer in a diabetic with an A1C of 12. There's tendon exposed. It's gross. There was underlying vascular disease here. This patient had a revascularization procedure performed and then received negative pressure, and then a split thickness skin graft was done. Is this wound ready to receive a split thickness skin graft? No. So what happened? It failed, right? So now we have a big giant wound with an A1C of 12 with a failed skin graft, and this is when this patient shows up to us, right? Now the surgeon says, okay, off to the wound practitioner you go. And this is when we inherit this patient. So this patient needed some wound bed prep, not ready for Becaplermin yet. This patient got sharp debridement plus enzymatic debridement with Clostridial collagenase until we had healthy granulation tissue established. We see those granulation buds there. Becaplermin was started, and now watch what happens. Every 2 weeks, this thing's going to start to shrink up and get smaller and smaller and smaller and smaller, and after just 12 weeks of Becaplermin, that big, giant, nasty wound completely healed. We're going to welcome Dr. Lavery up to discuss the safety considerations in use of this product.
Thank you. So I'm going to talk about safety issues with this product, and I think it's really interesting because it's one of those pieces that the dominoes started to fall, I think, based on information that most people wouldn't accept to make a decision. So I think it's fun. It's interesting information to share with you. Some of it has been published. Some of it is not yet published. So I really want to talk about the box warning that's associated with this platelet-derived growth factor. I want to discuss animal research and the risk of cancer and adverse events or platelet-derived growth factor in other applications that don't have to do with wound healing. And then I want to finish by talking about some epidemiologic studies, several of them that talk about safety and complications in people that receive this product. So the box warning for platelet-derived growth factor, the FDA received information regarding a study that was performed. So it was really based on information that wasn't published. So it's difficult for us to critique because we don't have the paper to hold in our hands. It was based on using some health insurance database. And actually, let me show the next slide. So this is the box warning on this. It says, and I want you to, think if this makes sense to you. So there was an increased rate of mortality, of death, of people dying, secondary to malignancy, observed in patients with 3 or more tubes of commercially available platelet-derived growth factor in a post-marketing retrospective cohort study. Following the publication of an abstract suggesting this, but not an increased risk of the incidence of cancer systemically, all cancers, the incidence of cancer at the wound bed, an incidence of mortality. So this resulted in people reading this and being educated about it and having a concern, decreasing the use. In some institutions, there were restrictions on the utilization of the product, and the FDA asked for more information. So a really interesting, kind of scenario. Presented data that's not published, and there was a box warning. So there's been a long-standing theoretical concern, and in medicine we have lots of theoretical concerns that change our decision process, change what we have our patients spend money on, that don't eventually result in evidence that theoretical concern really works or has a difference. We do it all the time. And I think a problem if you look at the evidence in wound care over the last 20 years, 20 years ago we were doing hand puppets and talking about this is my experience. There's been a huge volume of data and higher quality studies to give us more information. So I think Susie started talking about this earlier, so this kind of falls into what happens with basic science and how platelet-derived growth factor impacts every stage of wound healing. It alters the expression of platelet-derived growth factor, and it's been associated with the concern of increasing the growth of tumors in the wound bed or distally. If any of you have participated in phase 1 studies of topical medication, one of the things they do is they look for a systemic signal or systemic dosing. And it's really hard to put something on a wound and get a systemic response. So there's emerging data that what I really want to talk about is some of the animal data that I thought was really interesting, some bone graft data. Both of those applications use systemic application or a higher or a concentration of internal use of the product. So you would expect, obviously, if you get an intramuscular dose, an intravenous dose of PDGF, that it's going to have more of a systemic effect. And then finally, about the epidemiologic data that really talks about the application of commercially available platelet-derived growth factor in large patient populations looking at malignancy and mortality. So this is a table of animal studies using rodent models, and most of them, if you follow this, have intravenous administration of the drug, and then this bone graft product that is platelet-derived growth factor combined with a bone graft product. So these are the studies that I thought were most interesting. So when you look at rodents and look at injectable platelet-derived growth factor and see if there's any maternal toxicity or toxicity to the fetus, there wasn't. Actually, all of these studies are negative. If you look at animal models where they take a bone graft product substitute with platelet-derived growth factor, there weren't any abnormal signals in rodents. So the next piece that I thought was interesting was looking at what happens with the bone graft. So this is a product, augment bone graft, where they use a resorbable synthetic bone graft with platelet-derived growth factor in the product. So you're gonna have a synthetic bone graft, and you're gonna have this fabulous platelet-derived growth factor to facilitate wound healing and release of growth factor while this heals. So this was approved in 2009 for foot and ankle fusions. This is the table, and I know it's busy for you. If you're interested, you can go to this reference. But if you look at this, so these aren't huge studies, but if you look at the data that uses this product, there's not a difference in systemic malignancies in people that get active or traditional autograft. So, another interesting piece of information. So this is the J&J cancer study data. So this is looking at epidemiology evidence of patients that are being treated with commercially available topical platelet-derived growth factor. So if you look at this, it's actually a 20-month follow-up, so a really short period, a small number of patients, 291 people exposed, 9 cases or 2.7% in the active treatment group, 200 in placebo, 1%, not statistically significant, a small sample size. So then this I3 study data, which is a much larger patient population, 1,622 people that have active treatment with the product, with 2,809 patients that are controls that didn't have any treatment with the product. And a very sophisticated analysis. It used a research database. It followed people initially for a 20-month evaluation period. And in the active treatment group, there are 28 confirmed cancers, 9 cancer deaths. In the control group, 43 confirmed cancers, 16 cancer deaths. And if you look at this, none of these events are significant when you analyze this data. There was no increased risk of either malignancy or malignancy-related deaths from this study. So that was a 20-month follow-up. So then the next part of this was a 9-year evaluation of this patient population in this data. So now you have a large number of patients for a 9-year evaluation. And again, if you look at deaths or any kind of malignancy, it's not statistically significant. If you look at people, if you're fishing for some signal and you look for people that have been prescribed 3 or more tubes, again, it's not a statistically significant increase or change compared to people that didn't get this treatment. Okay, so for the next piece of this is a bigger, larger study, longer study with VA data. So this is not yet published data. Some of this was presented 2 years ago at this meeting, and this is still out being reviewed, and hopefully will be presented soon. So this is a large retrospective observational database or data set with the VA. With the VA patient population. It included VA patients from 1999 to 2007 with diabetic foot ulcers with no prior cancer. The primary outcome was the number and the rate of incident malignancies in patients who've used platelet-derived growth factor and patients who have not been exposed to the product. Let's see. The secondary outcome was the number of platelet-derived growth factor doses associated with the risk of incident cancer or incident cancer deaths. So large patient population, 6,429 people who were users of platelet-derived growth factor, 12,858 patients who were not users. So again, this was limited to people that had no prior cancer, up to an 11-year follow-up. So this was this is a group that has used the VA data for a lot of different evaluations. So they go deep in the data. It's a very sophisticated epidemiologic analysis. So if you look at the incidence of cancer and cancer risk, so these multivariate regression model. So none of my animation ever comes up in here, I guess. So first of all, if you look at overall the cancers and other malignancies, skin cancers and other malignancy, again, not a significant difference in people that received treatment and people that didn't receive treatment. The cases, this is the number of cases per year, the person years of exposure. And then, so the next piece is looking at all other kinds of malignancies. So looking at cancers was not significant. None of these other factors are significant either, which to me makes sense for a product that I think is unlikely that you're really going to get a systemic effect. So next time I'm going to show you the survival analysis. If you use the other part of your brain, and you need to see pictures like I do. So this is malignancies other than skin cancer. So looks like the survival analysis essentially overlaps each other. So there is no significance in cancer incidence between the two groups. If you look at basal cell and squamous cell, same thing. No difference between the two groups. And if you look at cancer deaths, no difference between the two groups. So here's the looking at the dose response. So if you look at people that had no exposure to this product, 1, 2, or 3 or more tubes, again, same trend. There's no significant difference in the events of interest based on their either using the product or the dosing of the product. So to summarize, I think that the animal data is interesting and compelling. More systemic exposure than obviously people are going to have using a topical product. Same thing with using this product as part of fracture healing with bone graft substitutes. No change in malignancy. And then I think there's evolving data that obviously we can explore in greater depth than the original abstract that created this concern. All of the data so far does not suggest that there's a concern. So I think when the VA data is published, it I think will be a robust evaluation of this, and I think will help us kind of put this concern to the side and perhaps influence the FDA to change the box warning on this product. So with that, I will stop, but we'll there's a microphone if y'all have any questions for Susie.
Hello, Dr. Joseph Smith, All-American Podiatry and Wound Care, Virginia Beach, Virginia. Yesterday, we heard a lecture from Dr. Benjamin Almquist from the Imperial College of London, where he stated that his research showed that growth factor really didn't, Becaplermin that is, didn't really seem to have an effect versus placebo in his studies. And furthermore,
in clinical studies.
Right, and furthermore, that the growth factor dissipated in about 2 minutes. What is your response to that?
So I'm not familiar with his work. I don't think I don't know what his study design, or I'm absolutely completely unfamiliar with the evidence you're talking about. So I could comment, but Susie's going to knock it out of the park.
Is this on? Yeah. Yeah. Where was his data published?
I just was at a lecture yesterday in the scientific portion of the seminar, so I'm just telling you what was presented yesterday.
I would love to see his data. I have not seen that. I'd like to see it in a peer-reviewed journal. I'd like to see it in a prospective randomized controlled trial with 400 patients. And if he has that, absolutely we need to look at that. The bottom line is we have a very, very well-designed study that has been picked apart numerous times that shows that efficacy, again, at a statistically significant level. So that's what I'm going to base my decisions on until I see other published data.
I think the other thing that I would say is if you look at what the standard of care was when this study was done, I think this is a better product when it's combined with more aggressive offloading and more aggressive wound debridement. I think at the time, those were not stressed in diabetic foot care, and I think there's been a body of work that talking about just the benefit of those two treatments. And I think that if you look at good wound care, more aggressive offloading, more aggressive debridement, including platelet-derived growth factor, I think the product will show better and the results will be better. It's a different world since this study was designed in the early 90s.
And forgive me if I repeat something that Susie said, but I can't resist, given the question that was asked. I did those studies we talked about for a reason, so that to make the point, it's so important what guides our decisions, and that we make our decisions based on really good evidence. And I'm going to repeat what Susie said. Like I said, forgive me for being repetitive, but it's so important. That study that she showed is a double-blind, multi-center, parallel group, randomized control trial. That is the highest level of evidence that exists, with 382 patients. And the study that she showed that the patients that got the Becaplermin healed on average 6 weeks sooner than the placebo group. That's the kind of study that needs to guide our decisions.
And then I have one other comment that I have to make about the timing. It is well known that, in a wound that is clean and, free of necrotic tissue, where you have viable cells with receptors available, that PDGF binds instantly to those cells. In terms of how long it lasts in the wound environment, what's important for you to know is that in phase 1 animal studies, phase 2 studies, and then this phase 3 study, in the early studies, the phase 2 trial published by Steed, it was a dosing trial. So, basically, whenever you're looking at a drug, you have to decide what doses you're going to use. So the particular dose with the 100 micrograms per gram applied once a day is the one that showed efficacy. So in terms of, we're looking at efficacy, not necessarily how long it lasts in the wound.
Yeah, just to follow up on the strength of data. So that VA data has been available, the larger VA data, right, the 6,000 patient data, for 3 years now. Question is, why hasn't it been published already? That's one. And number two is, where do we stand with the FDA in getting that box warning removed?
So since none of us are authors on the VA paper, I think we don't know why it hasn't been accepted, or the timing or where it's gone. So we plead ignorance for the first charge, and so I think the FDA is evaluating information and making a decision about the box warning now.
I'd like to also address that I was talking to, all of us know Dr. Miller, who did that study. Awesome guy and presenter. And this has been submitted for publication. It's been submitted to Drug Safety for publication. We're hoping to hear fairly soon as to whether or not it was accepted. So it should be published soon, because it's very, very good data. And then the second issue is I understand through the grapevine that it has been submitted to the FDA to remove that box warning. So we're hoping that will come off.
Hi. I have used PDGF, Becaplermin in the past, and quite honestly, the reason we stopped was that the instructions to use it were a daily dressing change with gauze. And I was wondering, is there anything in the pipeline to develop perhaps a slower rate of release of this product, kind of update the product, and allow it to be used with perhaps a foam dressing?
So the comment was about the utilization of the product, and the manufacturer suggests that you apply the Becaplermin and cover it with a saline moistened gauze. They have to suggest it that way because that's the way it was trialed. And the comment from the audience was that she has stopped using it because she didn't want to use a saline moistened gauze. And I jumped on my co-presenters here wanting to answer this myself because I don't want to use saline moistened gauze either, right? How many times did we talk about evidence-based medicine? There is no literature, no good studies that exist to suggest that a wet-to-dry dressing is useful in wound care. So I can share with you, I don't cover mine with a saline moistened gauze because I don't want saline moistened gauze on my wounds. And actually, the comment specifically was about foam, and I can share with you that's actually what I use the majority of time. Has a really nice range of levels of absorption it's capable of handling. Most of these foams can do anything from mild all the way up to heavy drainage, and I'm covering mine with foam most of the time. And then the other question was, is there anything being planned to change that recommendation? I'm not aware of any studies being done to change what the manufacturer recommends. So my answer would technically be off-label by not doing it the way the package insert says, but that's how I do it. I'm totally comfortable doing it, and I've had excellent results doing it that way.
I do want to mention, also this is off-label, but I do want to mention that EMBIL, E-M-B-I-L, et al. Published a study in the early 2000s that replicated the Wieman study. It was prospective, but it wasn't blinded because they took, I'm trying to remember how many patients it was. I think it was around 150 patients. It was fairly large, and they followed, again, they followed the Wieman design, but they applied the Becaplermin once a day, covered it with Adaptic and gauze, and then looked at healing rates. And they actually got healing rates a little bit higher than the 50% at 20 weeks. It was 53 to 57%. I just can't remember off the top of my head, but it was a little bit even better. So again, in that particular study, again, different from the package insert, but that study showed that just Becaplermin, Adaptic, gauze, you got even better results than you did in the Wieman trial.
So there's
by the way, I'm comfortable. Let me just say this. I am very comfortable with the daily dressing change because it's super easy. Patients can do this themselves. Occasionally you have a patient that can't reach their foot, but most patients, either themselves or have a caregiver, can apply a thin layer of gel to a wound, cover it with Adaptic and gauze, and change it once a day. So I am very, very comfortable with that wound care.
So someone sent up a comment about there's a second VA study. I mean there's more data, but they only gave me 12 minutes. So I mean, so the other thing about people always ask, do I have to just put this on once a day? Can I mean, all kinds of other off-label applications. So, you know, what you're going to get is exactly what was discussed. You're going to get the way the study was designed. People do variations all the time. It does not mean that, you know, someone from Smith & Nephew is going to knock at your door late at night and say, you know, we're taking you out because you're using this twice a day. Or anyway, other questions?
When I've read the package inserts, it says twice a day dressing changes, once with the Becaplermin in 12 hours, and then 12 hours later a dressing without the Becaplermin. I was wondering if that was a pulse effect. But here in Dr. Lehman's pictures, he has a picture of the gold standard of healing. Dr. Lavery has talked about the gold standard of healing. I think I remember you're showing with TCCs you're getting healing in less than 2 months. It becomes impossible to use that kind of gold standard for this kind of foot ulcer if you're having to do dressing changes twice a day, once a day with gauze, or once a day with foam or any other thing. You can't let the patient take it off, and that improves the behavior, which is probably the reason why they got the ulcer in the first place and why it doesn't heal very quickly.
I bet all three of us have comments about that because I think that's a really, really good point. And let me just start because I have the mic. First of all, I totally agree that, you know, when you look at studies across the board in total contact casting, in the appropriate patient, you can get very, very fast healing rates. And I frequently say, we do contact casting in my clinic. I frequently say you can grade the seriousness of a wound clinic as to whether or not they do contact casting because it's an absolute tool that we have to have in our armamentarium. The reality is, though, is that every patient is an individual, and not every patient is either going to be willing to contact cast, can make it into the clinic weekly for contact casting, or are candidates for contact casting for a variety of reasons. So I had a patient recently who was a perfect candidate for contact casting. He absolutely refused, no way, no how. He wouldn't do it, but he was willing to use crutches. He was actually able to use crutches because he was strong enough, and we could put him in a simple off-weighting shoe that off-weighted the forefoot and use Becaplermin, and he was healed in 6 weeks. So, I mean, you have to look at the particular patient. There are certain patients where you absolutely are going to go to a contact cast, and other patients where it's not appropriate.
And part of that comment was the package insert and the manufacturer recommendation about this every 12 hours business. So the way it was trialed, so the way Smith & Nephew representation will tell you to do it is Becaplermin, cover it with a saline moistened gauze, leave that in place for 12 hours. After 12 hours, remove the saline moistened gauze, rinse the wound bed clean with saline, apply another saline moistened gauze, and then continue to go 12 on, 12 off, 12 on, 12 off in that pattern. That's the way it was trialed, so that's the way they have to suggest that you do it. I don't do it that way. I think I've heard from my colleagues here that they're not really doing it that way either. I think the every 12 hours thing is crazy and unrealistic. We can't get visiting nursing to come once a day, let alone twice a day, right? That's not happening. I think it's confusing for the people. I am totally comfortable, this is off-label, I am totally comfortable telling my people to do it once a day. I have had, and this is anecdotal, this is not a randomized controlled trial, but I've certainly had no adverse events as a result. And as far as total contact casting, no question, gold standard. I'm doing a talk on it at 4 something today, please come. But we have studies that show us, of all wound care centers in the country, between 2 to 6% of wound care providers are applying total contact casts. So that's a lot of patients that need a different treatment option. And this is again off-label. Don't sleep on applying Becaplermin under your total contact cast. That's a nice option.
How often do you take it?
So, and the follow-up question was, if you do that under a total contact cast, again, it's off-label, how often do you change it? As often as you change the cast, once a week or twice a week, depending on what the patient needs.
Other questions? Well, thank you very much.
The comment was, I'd cut a window in the cast. I'm going to disagree with that. If you cut a window in a total contact cast, it is no longer a total contact cast.
But I would also, but I'll also tell you, there's a nice study from Italy where they used a window total contact cast and got excellent results. I mean, so part of the benefit of a total contact cast is it's heavy and people don't walk as much and it changes their gait. So, the total, it may be more activity restriction than, what we think of as total contact cast. Thank you for...
Wait, I want to make one more comment about that. One thing that we're doing in our clinic every once in a while, because, one of the problems with a removable off-weighting device is that the patient doesn't wear it. But we've had some success in certain patients where we have our Orthotech clamshell, the contact cast. And they still redo it once a week because we want to redo that thing. But he does a contact cast, and then he clamshells it, and then he attaches this self-adhesive Velcro to keep it in place. Sometimes we'll even wrap Coban on it so the patient, doesn't take it off. But generally, again, if we want the patient to take it off every day to apply Becaplermin, we're going to just use the Velcro pieces, and then that allows them to apply it daily. Thank you for your attention.